Assalamu alaikum. The long clinical consultation day. First scenario, you are the medical registrar in the hypertension clinic. You will see Mr. Kevin Rice. He's 34 years old man who has been referred by his GP because of persistently elevated blood pressure on several occasions. Take history and examine the patient, address his concerns. Okay, ready?
Hello, I am Dr. Muhammad. I am one of the doctors here today. I need to confirm Mr. Kevin, 34-year-old, with me.
Yes, I'm Kevin.
Okay, Mr. Kevin, we are here today to discuss some health issue for you. I will take some history and examine. All will be. You will write some notes. All will be confidential if you don't mind. Okay.
Yes, doctor.
Can you tell me in your mind, in your word, what brought you today to the clinic?
Honestly, doctor, I feel completely fine. I don't know what's going on. My GP just noticed that my blood pressure has been high recently on different times. It was sometimes 150 over 990, sometimes 145 or 100. So he was worried about that, and then he referred me here.
Sorry for what's happened for you, Mr. Kevin. But I need to confirm before you go to the clinic, any stressful condition there or anything there before you go?
On the same day of the clinic, you mean?
Yes. Every
No,
time the blood pressure at the
nothing
time.
special. It's the normal stresses in my life, but nothing special in the same day, and it was on different days.
Okay. You were going there as a routine for you for the clinic or any symptoms were there or you
No,
complaining
no,
anything?
nothing at all. I was just going for a routine checkup.
Okay. Let me ask you, this started since when?
I think for the past 3 or 4 visits, my blood pressure was high. Then the GB asked me to come to check my blood pressure many times, and all of them were high.
For how much time this?
I checked it for 5 days, 5 consecutive days, and all of them were high.
Before this, everything was okay. Last time measured normal when?
Last time that was normal, I think it was, I'm not sure, maybe a few months ago.
Since this
Nobody
time,
told me anything, yeah.
okay. Since this time, you noticed any headache there?
No, not at all.
Any problem in your vision?
No.
Any change in your weight, increased or decreased?
No, I have not noticed. It's my same weight since before.
You noticed any heart racing?
No,
Any chest pain?
no,
Okay. Any shortness of breath?
no,
Any weakness in any part of your body?
no,
Okay. Any altered sensation in any part of your body?
no, doctor.
Change in your speech?
Never. I haven't noticed.
Increase your hand size or ring size?
No,
Any your face feature changed over this time?
no, doctor.
Okay. You noticed any lump or bump in your body?
No,
Okay. Any joint pain?
no, doctor.
Any back pain?
No, I don't have any back pain, and unless if I'm sitting for long hours, but it goes away like any back pain.
Since when this back pain?
What?
Since when?
Yeah, it's a long time. It has been forever, many years now. Whenever I'm sitting at my work or sitting in the taxi that I'm driving, I'll be sitting the whole day. That's why when I go at home at night, I feel like my muscle, there is some strain in my muscle. So it gets relieved after I rest for a while.
You feel any cramps in your muscle?
No, not necessarily cramps, just some mild pain.
Mild pain in the back and then in your muscle after long time sitting, right?
Yes.
Any change in your sensation in your leg?
No, not at all.
Any weakness when you stand up?
No.
Any skin changes in your hand or arm become more tight?
No.
Any rashes or skin changes over your body, especially when you exposed to sun?
No.
Any dry eye or dry mouth?
No.
Any difficult swallowing?
No.
Any weather preferences, especially to hot or cold intolerance?
No, doctor.
Any swelling in front of your neck?
No.
Any tummy pain?
No.
Any change in your water work? You noticed increase in urination or water work?
No, doctor.
Any color changes in your water work? Become more red?
No.
Any loin, any back pain, any pain around?
No.
Any change in your bowel work? Become more loose or
No, doctor.
any feeling sometime of flushing your face?
No.
Okay. Any past medical history of note I should to know?
No, doctor. I was completely fine.
Any medication you're taking over counter for anything? Or herbal
No.
medication?
Nothing, doctor.
Any family history of note? Kidney problem or blood pressure problem?
Yes, doctor. My father recently he had a heart attack, and
Sorry,
unfortunately he passed away.
sorry for what's happened for your father. Sorry for your loss. Can you tell me more about that? Any diagnosis they
No,
investigate for that?
they just said it's heart attack.
How old is he?
He was 76.
Okay. He has any diabetes or hypertension or anything?
Yeah, he has high cholesterol, he has high blood sugar and high blood pressure. But all of this was in his last years, his last 5 years. Everything happened.
That any other person in the family lost in a young age?
No, doctor.
Okay. Any other family history of note, clots or cancer or anything?
No, doctor, not at all.
Any surgery for you or procedures?
No, I just removed my appendix when I was 21 years old.
Sorry for that. Any blood transfusion or any event at this time?
No. All was good. I just stayed in the hospital for 1 or 2 days.
Okay. Any allergies?
No.
Okay. Any, sorry for this question, any illicit drugs you are taking or party
Mm,
drugs?
no, not at all.
Sorry for this question, you have long-term partner?
No, doctor.
Any casual relationship?
No.
Any piercing or tattooing or sharing needles? Sorry for this question.
No.
Okay. Do you smoke?
Yes.
How many cigarettes?
I use about 1 pack per day on the good days.
How much time?
It's been for the past 10 years.
I'm advising you to strongly, we need to stop this smoking because it may help us in controlling your blood pressure. It's okay for you?
Okay.
Okay. Any alcohol intake?
Only socially.
No binge drinking?
No.
Okay. Any coughing?
No.
Okay. No coughing blood, no coughing phlegm, anything?
I know nothing.
Okay. What's your job, Miss Calvin?
To be honest, doctor, I since my father died, I have been working 2 jobs. I work in the morning as a taxi driver, and I have another shift as a cashier in a supermarket. So usually every day I work 16 hours.
I'm so sorry for this, Kevin, and this may be more stressful for you, and maybe some factor is affecting your blood pressure. We have
Yes,
here
it
our
has been
first
really very stressful for me recently, and I'm grieving, and right now I'm the only one who is supporting my family. So
doctor.
these days are really hard.
Sorry for that. We will see with our occupational and social team how can we help you. Okay?
Okay, doctor.
Can I examine, please?
Yeah, sure.
Okay.
What do you want to examine?
How is body mass index of the patient?
His body mass index is 31.
31. 31. Okay. What about I need to check her vitals, blood pressure, and pulse equal, symmetrical. Any change between both sides?
Okay, blood pressure is in the right hand is 150 over 90. In the left hand, 155 over 91. Pulse rate is 70 beats per minute. Synchronous.
Okay. Any delay?
No delay.
Okay. Any special character for the pulse?
No.
Okay. Any specific character, specific in her hand, atrophy muscle or any spade hand, large hand, anything?
No.
Okay. Any tightness of the skin?
No.
I will ask him to stand up. Any proximal myopathy?
Any what?
Proximal myopathy.
You will just check by asking him to stand
You
up.
will ask him to stand without support.
He can stand.
Okay. I will tell him to stand his hand. Any pronator left there?
No.
Okay. I will check any pallor, any jaundice.
No.
I will offer a fundoscopy. Any hypertensive retinopathy there.
No need, doctor.
I will check vision field. Any problem in the vision field.
No.
Okay. Any tongue, large tongue, or sores, or say noses, anything?
No.
I will ask to tab for the neck size. How much neck size?
It's within normal.
Okay. Any neck swelling?
No.
I will examine heart, the apex in place.
Yes, abexamine place.
S1, S2, any murmur, any gallops, any special murmur of the pulmonary and the aortic area,
No.
the mitral area.
No.
Okay, I will examine chest firstly, upper zone, any rails or any special.
Doctor, your voice is breaking.
I will check the chest firstly, any basal crackles.
No.
In the subclavicle area, any machine murmur or any murmur subclavicle on the left side.
No.
Abdominal examination, any masses or swelling. I will check for abdominal aorta, any pulsating or any pulsating mass there.
No.
For kidney, any splenomegaly or hepatomegaly.
No.
Palatable kidney there.
No.
Berwi all over both kidney.
No, Broir.
Okay, okay, Miss Kevin. I will check lower limb, any edema there, any rashes.
No edema. No rash.
I need to ask you have any headache before?
No, doctor. Just mild headache when I'm tired or like that, but nothing special.
No, when you awake at the morning, your sleep refreshed after sleep, no headache there.
Yes, everything is fine.
Okay, Miss Kevin. Anything you want to talk
2
with
minutes
me?
left.
What?
Anything you wanted to talk with me? I didn't mention during my talk. Anything significant for you?
No, doctor. I think that's it.
I asked before, no heart racing?
No, no
No
heart racing.
heart racing?
Nothing.
Okay. Okay, Ms. Kelvin, can you tell me what's your concern, please?
So doctor, I just want to know what's wrong with me, why my blood pressure is high. And I'm really afraid that what happened to my father might happen to me as well, because he had high blood pressure too, and he died, and now I'm the only one who is supporting my family. So that's what I want to know, if it's the same problem and what is the reason behind that.
Sorry for what's happened for your father. After taking the history and examination, we have a condition called essential hypertension, and this is related to your it's come no specific cause and increased by your stress in your life, like your job, with smoking also. That's why we advise you will help in this issue, and we advise you to stop smoking. We will do some lab investigation to rule out any other causes. Then we'll start some medication for control your blood pressure with sharing our heart doctor and medical consultant with us. And what's happening for father, after controlling this, we will decrease the chance to have this by compliance with treatment and instructions. Okay for you?
Yeah, but doctor, the GP told me that given my age, it's unlikely to have hypertension without a reason. He said that it might be my kidney. Do you think it's my kidney?
From the history and examination until now, is not clear. But as I mentioned with you, we will do some lab for your kidney and for some hormones and for some lipids to confirm the diagnosis. Sometimes it is coding by kidney, by another causes can be. But from examination and taking the history until now, it is not clear. That's why we need to do some lab to confirm and imaging to confirm this. And this also related to your some cramps that happen to your limb that may be related to some blood channel narrowing related to your kidney, and we'll do imaging for that to rule out.
I didn't have cramps in my legs, doctor.
Okay, that's why we need to run this lab and to rule out other causes to be in safe side.
Okay, doctor. Okay.
Okay, time's up. Examiner
Okay.
questions.
So, doctor, present your case, please.
We have a 34-year-old male with persistent hypertension discovered since 5 days back with no symptoms, asymptomatic. No clear secondary cause for the hypertension, including endocrine like pushing acromegaly, renal problem by
Okay,
history.
what's your differential?
My differential essential hypertension, occult hypertension. Maybe the patient going to the clinic was after stressful in his job. So we need to confirm by ambulatory blood pressure monitoring also. Lastly, we need to do routine lab to rule out the common secondary cause for hypertension.
Okay, what are these causes you're talking about?
We need to see renal artery stenosis, polycystic kidney disease.
What else?
Hmm?
What else?
Endocrine pushing, hyperadrenalism.
Okay, what else? Okay, how are you going to manage this patient?
Until now, we will do at the one clinic day. We will run basic lab for basic lab for CBC, ASRP for electrolytes, especially sodium potassium, to see if there is hypokalemia, hypernatremia. We will send the cortisol level, 24 hours cortisol urine. We will send also metanephrine and catecholamines. We'll do some to TSH. We'll do imaging for ECG and echo. CT aorta for rule out any coarctation of the aorta. We'll send the renal ultrasound abdomen and renal artery Doppler. Also aldosterone renal ratio at the lab also to rule out cons and hyperaldosteronism. We'll send.
Okay, doctor, suppose that this patient had low potassium. What do you think your differential would be? What's the only differential you will consider given the history and examination if his potassium was low?
If potassium was low, it will be Cone syndrome.
Okay, and if I gave you a chance to ask this patient one question, what would you ask him in the history?
History. I asked about any cramp in his muscle, any heart awareness, any.
Okay, how are you going to treat this patient?
After confirming if there is secondary cause, if it is there is hypokalemia and the renal ratio is high and onto the Cone syndrome, by multidisciplinary team, nephrologist and endocrinologist will start aldosterone, will start spironolactone for him after giving counseling and education for the patient, counseling education for the patient for hypertension by low fat salt diet, about exercise, about weight, and uh, if it is essential, also by this lifestyle modification, then we'll start by his age, calcium channel blocker, like amlodipine, then titrate up by ACE inhibitor or with.
Okay, are you gonna start ACE inhibitor in this instant?
In A?
Are you gonna start the ACE inhibitor?
I will, as if the confirmed Cone syndrome.
Before even any diagnosis, are you going to start antihypertensive?
No. Without any diagnosis, I will start by his age by calcium channel blocker.
Okay, that's great. Thank you very much, doctor.
Okay, you can comment now, Dr. Gutuf. Well, time is up.
Okay, regarding this case, regarding his history taking, it was good. He covered most of the causes of the secondary hypertension. Even though he was a bit unorganized by cutting the systemic review, going to the past medical history, drug history, then coming to the systemic review, then going back to drug history. So it was a little bit unorganized, but it was a really good history. He did ask about most of the common causes of the secondary hypertension. And regarding the physical examination, he did examine everything. But given that in the real exam, you don't actually have time to do all of this. So, for example, in the abdominal examination, you started by doing hepato checking for liver and checking for spleen, and it will take much time in the real exam. And then you went for the kidney as the last thing in your examination. So one of the most common causes of secondary hypertension is kidney problem. So after you check for the peripheral signs or any endocrinological disease or any rheumatological disease, I believe that you have to go to check for the kidneys for any renal artery stenosis, if you find any bruit, if you find any polycystic kidney. Suppose that this patient might have polycystic kidney, you might have it right away. So if you lost your time in checking the spleen and checking the liver, auscultating the chest, auscultating the heart, yes, you have to auscultate because you need to rule out any hypertensive emergency. But to be realistic, you cannot do all of what you said in the exam because it's easier to say than to do. So this is regarding the physical examination, but you did cover actually what should be covered. And the other thing in history, back to the history, you did everything regarding the secondary hypertension, but regarding the essential hypertension, uh, since you didn't find any symptoms suggesting of any secondary hypertension, you should explore more the risk factors of essential hypertension. So this patient already volunteered to you that he's being very stressed lately due to family issues, financial issues, and he's doing night shifts, and he's already overweight, but you should ask more about the diet and exercise. And this patient now is having everyday fast food and salty diet, and he is not exercising at all, and he is not sleeping well. And this is one of the most important things you have to, this is a positive finding in this case, that this patient has many modifiable risk factors for the high blood pressure. So yes, given his age, we have to think about the secondary hypertension, but the essential hypertension is actually very common, especially lately, and in such patients. So regarding the concern, you did answer both of the concerns well. And regarding the discussion, first of all, the management should start by modifying the risk factors, the sedentary lifestyle, to ask the patient to exercise more, and you did well by referring him to the social worker, the psychologist regarding his stress. So just to sum up the case, the causes of secondary hypertension that we should consider, this case is actually about exploring the options of the causes of secondary hypertension, and if it's not there, we have to also search for the risk factors for the essential hypertension. It doesn't have to be secondary in this age. So as you did, we have to rule out any cardiac causes like coarctation of aorta, any kidney problems like kidney stones or glomerulonephritis or polycystic kidney disease, and we have to ask about pheochromocytoma symptoms like episodic headache. And then the medications, I'm not sure if you asked about any herbal remedies, but you did ask about the medication. He wasn't taking any.
I asked if any help with this.
Okay, that's good. So the herbal remedies is one of the causes, such as licorice, because I think it was a case that came in Egypt. And then the endocrine causes, the thyroid gland, the Cushing disease, and primary hypoaldosteronism. The leg cramps, you said to the patient that since you have leg cramps, we are considering that. The patient did not say anything about having a leg cramp. So you cannot force a symptom on the patient. And regarding the family history, you already did that well. And other than that, I have nothing to say. Just the the examination was very lengthy and not really focused. But you did great, and I would like it more in the consent if you give the patient safety netting, to tell him to stop caffeine and NSAIDs, for example, and to tell him if he feel any blurry vision, if he had any weakness, if he had any chest pain, to come directly to the hospital. That's it. Thank you very much, doctor, for doing the case. You did great.
Thank
Okay,
you.
thank you. Thank you, Dr. Gotov. I will just add to your comment the skin rash for neurofibromatosis and association of neurofibromatosis. I think this musculoskeletal system, Dr. Muhammad, you missed or you asked? Joint pain,
I asked
skin
it
rash.
up to dry
You
eye,
ask
dry
about,
mouth. I think asked about musculoskeletal.
yeah, take care of the skin rash as neurofibromatosis comes in the exam along with the association of neurofibromatosis. So it's not the case, but it can be associated with pheochromocytoma or renal artery stenosis. The epilepsy, also tuberous sclerosis with polycystic kidney disease. These are common case coming, and it might be presented with hypertension. Otherwise, I think you cover all the causes. Add to them also the Berwi, the examination. Berwi over the renal artery, you have to auscultate. I think you did the ballotment only, but you didn't do the auscultation, right?
I bought
You did?
auscultation for Berwi
Okay,
in the
that's good.
aortic stenosis, lower coarctation, and then the kidney.
It's
But the
good.
doctor
So
is
don't,
right. I lensed the examination. I should do peripheral and general, then على طول direct to the heart, vision fastly,
yeah.
and go to the kidney. That's right.
Okay, don't forget the white coat hypertension. Also, it can be
I mentioned, Dr. Bassam, I mentioned.
in the differential or in
Yes,
the history.
I mentioned white coat if the patient, I need to confirm by ambulatory blood pressure.
Exactly, yes. So you have to offer the ambulatory blood pressure at home. Otherwise, I think you cover all of them. In summary, as you said, the cardiac causes, aortic stenosis or coarctation of aorta, the endocrine cause, as you mentioned, the acromegaly or polycystic or Cushing syndrome, sorry, and hypothyroidism, hyperthyroidism. Don't forget the shakiness of the hand, the sweating of the hand for pheochromocytoma. And the other cause will be herbal or drug induced. You ask about illicit drugs. I'm trying to summarize, not for you, this is for all, for others, I mean. Then we mentioned the endocrine, dermatology, systemic sclerosis. So you can categorize by the system, endocrine, rheumatology, cardiac, or even drug induced by illicit drug or herbal. And as I said, the skin rash for neophromatosis and the association. And the most common, and you have to roll them out, the renal causes, which is on top of your differential. It's possibly in such age. So you have to focus on this part whenever you have 30 to 50. Essential will be around 50 years, but since you have 30, so this is secondary causes. You have to think about the renal cause, the artery stenosis, Cohen syndrome, and the other hyperaldosteronism causes. I think all the skills here was covered or were covered by Dr. Muhammad, right, Dr. Kutuf? You want to evaluate regarding the skills? The
No,
differential? Yeah.
that's right. Yeah, that's okay.
The differential were okay, right? Differential
Yes, the threshold was okay.
concern, the clinical communication, the identify the finding, physical examination, all of them. Don't forget always to categorize your answers, work up as general or specific bedside, and imaging. Lastly, the invasive. And don't say to the patient, we will do some labs. I'm not sure, is it, I think it's jargon. So you can say workup. We are doing some workup. Lab means laboratory, which is something medical term. So you can say, we will do workup to confirm your finding or diagnosis and to rule out others. Okay? Uh, yeah, I will post your scenario, Dr. Butov. Then we will read the comment quickly.
Okay, doctor.
So your patient, this one, in the chat box. Okay, you are the doctor in the acute medical unit, Mr. Razak, 34 years old. This gentleman presented with hand numbness and weakness for 6 months. Blood pressure 128 over 71, heart rate 71, temperature 37, saturation 99. Take a focus history, examine and address the concern. Yeah, back to the comment quickly. I will try to read all of them. But before starting, don't forget always the OSSA. OSSA can be either finding or it can be the cause. Okay, so here in this scenario, I think also Dr. Muhammad covered it during the history. I want also to focus on the systemic review. The system supposed to be from up downward. Dr. Muhammad, sometimes you are you're doing up and down. It will show the examiner that you are little bit disorganized because you ask about the water work, then you ask about the bowel. I prefer to do them in order. But in general, you cover all the systemic review question apart from skin rash. Quickly to the comment. High body mass index, smoking, yes, it could be related. Dyslipidemia, hypothyroidism, all of them can cause. Patient, Dr. Tahani. Patient have cramp. It wasn't there actually, but it's okay. Maybe you put it in your differential. So cramps, most likely hypokalemia, yes. Hypertension, need to rule out. Primary hyperaldosteronism, Cones, licorice, renal artery stenosis, yes, exactly. Dr. Ali or Ali and Lamar, hypertension with hypokalemia, Cones, Cushing, pheochromocytoma, little. By the way, little, it will not cause hypertension, hypokalemia only with normal blood pressure, okay? So you can mention it whenever the patient is having hypokalemia, but without hypertension. Lifestyle modification, of course, non-pharmacological option always start with and try to focus on this part. The diet, the exercise, not only in hypertension, even in diabetic patients. Dr. Amal summarized the causes of uncontrolled hypertension in young, essential, acromegaly, Cushing, pheochromocytoma, metabolic syndrome, polycystic kidney, scleroderma, cons, polyarteritis nodosa. Actually, you wrote the causes or the most common in PACEs. Vasculitis as polyarteritis nodosa, you will have skin rash also. Don't forget this as a differential. Secondary causes, Dr. Gotov. Aorta, coarctation, leg fatigue, claudication, cold feet, bad kidneys, urinary tract infection, stones, flank pain, edema, catecholamines, episodic headache, sweating, palpitation, pheochromocytoma, drugs, non-steroidal, OCP, steroid, cocaine, herbal remedies, endocrine, thyroid, Cushing, primary aldosteronism, cramp with hypokalemia. Good. So again, another summary. Dr. Amal, in this case, the diagnosis is essential. No, it wasn't essential. I think the essential will come at 50s, but maybe the stress was the cause here. So it's Dr. Gutov will correct. Is it secondary, right? Could you mention the differential in order again, please, Dr. Ahad? Dr. Hisham, Liddle syndrome can cause hypertension. I remember Liddle can cause normal tension, not hypertension. Okay, let's review it. Dr. Gutov, so the case was about only differential, or you want to mention or to specify?
No, it's a differential case. It could be due to the stress or essential, or it could be to other causes that doesn't have symptoms, because differential hypertension is usually symptom free. Even if the patient have any secondary cause, he can have no symptoms. So it's just a case of differential, and I think it came before the last year in Qatar with the same scenario. They couldn't
Okay,
find
so
anything.
it's a
Yeah.
case of
Yeah. This is the
differential.
real case that came before in Qatar, and the patient, they in the discussion they asked them if the patient was hypokalemic, what will be the differential, but it was just a discussion about the secondary cause of hypertension, and the patient was symptom free.
Okay.
So it could be due to his weight, stresses in his life, and the other risk factors of hypertension. He has all of the risk factors, and it could be as well a hidden secondary cause.
Okay.
Yeah. So that's
Thank you,
it.
Ruth. Yeah, so it's to revise all the causes and not to forget any of them. Yes, I revised the little. Yes, it can be associated with hypertension, exactly. Genetic inherited autosomal dominant. I revised it. Thank you, doctor. It's characterized by early frequent severe high blood pressure associated with low plasma renin activity, metabolic alkalosis, low blood potassium, normal to low level of aldosterone. Don't forget to add to your screen or blood test the bedside ABG in Cushing, and in Cushing you will have metabolic alkalosis. So always offer it whenever you are suspecting one of the hormonal affection. Okay. Little can cause hypertension with hypokalemia. Okay. Yeah, Dr. Ali or Ali and Lamar. Okay.
Yes, I
Sorry
think
if
that,
I
yeah,
mentioned.
so
Yeah.
the difference between hyperaldosteronism and
Yeah.
Lidl is that in Lidl both the renin and aldosterone will be low, and in hyperaldosteronism the hyperaldosterone will be high and the renin will be low. So otherwise all the biochemical abnormalities they are same. So it's basically based on the renin and aldosterone in both.
Yeah.
That's the
Ratio. Yes.
differentiating point here.
Yeah. So you have to mention the aldosterone renin aldosterone ratio. Okay. Our aldosterone ratio. You have to mention it to differentiate between hyperaldosteronism as primary or secondary causes. Usually, the secondary renal causes will be the ratio will be increase the renin and the aldosterone will be low. So the ratio will be low, right? Correct me if I am wrong. In the primary aldosteronism, the aldosterone and the renin will be high and the ratio will be low. So the opposite. Hyperaldosteronism or primary hyperaldosteronism, the aldosterone and renin, both of them will be high and the ratio will be low. But in the other all renal causes, the ratio will be high. Okay, clear for all? Anyone has comment before moving to the next scenario?
Dr. Basim, I think in primary hyperaldosteronism, basically the aldosterone level will be high and the
Yes.
renin will be low. So it is a state
Yeah,
of
the
low renin.
opposite.
So yeah, so
Yeah.
only
So
only
yep.
aldosterone will be high, renin
Yeah.
will be low. In Liddle syndrome, both aldosterone and what we call
The potassium, you mean these? Okay, let's revise it again. Okay, for the last time. The primary hyperaldosteronism, the aldosterone will be high, and
yes,
consequently, the renin will
Will be
be
low.
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 Yes, because
Yeah.
of negative feedback.
Yes.
And all
Uh,
other causes, the renin will be high and the aldosterone will be high. So the ratio in general will be low. The ratio itself will be low.
Yeah.
But
And in
in the
Lidl, just remember Lidl starting from letter L. So in Lidl, both aldosterone and renin will be low. So it is in Lidl, both the aldosterone and renin both will be low in Lidl. So just
yeah,
remember
yeah.
they are 3L, Lidl and renin and aldosterone, all three, all two things they are low.
Okay. Okay. Dr. Freddy, we can
Yes,
start?
doctor.
Yes. Here you go.
Okay, hello. My name is Dr. Abdussalam. I'm one of the doctors in the clinic today. Are you Mr. Razak?
yes, I am still with it.
Okay, nice to meet you. I'm here today to ask you a few questions about your health condition and examine you. Is that okay with you?
Okay, doctor.
Okay, could you tell me please what brought you here today?
Yes, doctor, this my hand, I feel it, some pain and numbness. Now more than 1 month, 2 months there.
Okay,
Suddenly, gradually started and increasing by time.
okay, I'm really sorry for your suffering. Could you tell me please more about it?
Yes, doctor, since 2 months back, I started to feel some numbness in the medial part of my hand, and by time I can't do my regular activity. Hardly I am doing it because of what's happening to my hand.
Okay, this is really hard, and I will try to help you in this regard. Okay, so let's talk more about this problem. So you said you had the numbness before you had this weakness in your hand. Am I right?
Doctor, yes, some numbness and the pain.
Okay, so which hand are we talking about?
My right hand.
Okay, so this is the first time you're having such problem.
Yes, first time.
Okay, so could you walk me please through the course of this problem? So 6 months ago, it started by just numbness and pain.
Yes, numbness and the pain, then gradually increasing.
Okay, and when did the weakness started exactly?
Uh, Confirm the time exactly, but by the time I feel my daily activities affected.
Okay, I'm really sorry for that. So regarding this pain, where do you feel this pain exactly? Could you point to me?
Yes, doctor, the medial part of my hand.
So you mean your thumb and your index finger and the middle finger?
Medial part, my little finger and my ring finger.
Okay. So so this is a pain, and you feel the numbness in the same area.
Yes,
Okay. Does this pain wake you up at night?
this all the time, doctora. Not specific time.
Okay. Could you show me your hand, please? Does he have any clawing with his fingers in a claw hand?
Picture Dr. Bassem is your.
Okay, let's continue the history. So,
Okay, I will share the picture now.
okay. So how severe is your pain on a scale of 1 to 10?
4 to 5.
Okay. So, regarding this weakness, are you able to hold the cup, for example?
Hardly, doctora. I
Okay. Do
do it,
you?
but hardly, not like before.
Okay, I will try to help you in this regard. So, do you have any abnormal sensation or any weakness in other part of your body?
No.
Okay. You,
Maybe my leg feel some numbness also,
your leg?
but not like my hand. It's since a long time there.
Which one of your legs?
Both my leg.
Okay. Do you feel any numbness there or weakness?
Yes, numbness, or light numbness.
Which part exactly? Is it in your feet?
Yes, both my feet.
Both of your feet. Is it up to the heel? It up to the ankle or up to the knee, for example?
I can't confirm this.
Okay. So do you have any weakness in your legs when you move?
No, I am moving good.
Okay. So do you feel like it's difficult for you to walk in the dark, for example?
I am not sure.
Okay. So regarding this hand problem, did you notice any cramping in your hands that come and goes or no?
Only pain Only pain, doctor, and numbness.
Okay. So, did you have any headache before or any abnormal sensation in other part? Hello?
No,
Any change in your vision or hearing?
no,
Any history of fits?
no,
Any abnormal movement?
no.
Okay. So, do you have any past medical history I need to be aware of?
Yes, doctor, I have diabetes since 8 years.
Since 8 years? Okay. And what are you taking for that?
Metformin,
Okay. Any other
500.
Okay, I will get back to that later. Do you have any other condition I need to be aware of?
No,
Okay. So, do you have any chest pain?
no,
Any shortness of breath or cough?
no,
Any coughing of blood or nasal problem like stuffiness, for example?
no,
Any nasal crusting or nasal blockage?
no.
Okay. Do you have any heart racing?
Yes, sometimes, doctor, I have some heart racing, but not affecting me little because I am working hardly.
Since when do you have this problem?
Since long time, but not affecting me. It is very mild.
Do you feel
Maybe
like
I
it's
take some
regular?
coffee.
What?
Maybe after taking some coffee.
After taking coffee. Other than that, you don't feel it.
No,
Okay. So, do you have any tummy pain?
no,
Any change in your bowel habit? Any loose motion or hard stool?
no,
Any tummy distension?
no.
Do you feel full after small meals?
Little for little. But doctor, my GP told me this normal with diabetes.
This is not what?
My GP told me this normal with my diabetes.
Okay. Do you throw up or feel sick,
No,
especially after meal?
some fullness only for a little time.
Okay. Do you feel any change in your water work? Any increased amount, frequency, or color? Changing color?
Yes, doctor, I feel some bubbling sometime.
Since when exactly?
Years back, also my GP told me and tell me you will control my diabetes. By time it will be okay.
Did you notice any clear frothiness?
Clear forousness is mild.
Okay. Any lower limb swelling?
No,
Okay. So, have you noticed any joint pain or skin rash?
in rash. No, but I feel something in my face. I don't know what is it. If you wanted to see,
Oh, show me, please.
Yes, it's shared already.
Okay, since when you're having this problem?
1 year.
1 year. So, is it itchy or painful?
No,
Okay. Is it increasing, decreasing, or the same?
yes, by time it is not like when it was little lesser than this. It's more now.
Okay. Have you seek any medical care for that?
No,
Okay. So, so have you traveled to anywhere recently?
travel.
Yes.
Maybe I went to Nigeria 3 years back.
Okay. So, regarding your past medical history, you said you have diabetes only. Are you on regular follow-up?
Not, I am not good patient, doctor. Every 6 months I'm going.
Okay. So, what about your last long-term blood sugar test?
7.5 one time and another time was 8.
Okay. Are you compliant on your medication?
Yes, I'm compliant, but sometimes I miss some doses.
Okay. Okay. You really need to be compliant on your medication because it decreases the risk of complications.
Okay.
Okay. So have you ever had any surgical operation?
No.
Have you ever been told that you had a complication related to your diabetes?
Only my fullness of abdomen, only my little bubbling. Yeah, they told me this is due to I am not compliant too much. That's why.
Okay. Do you have any family history of any of note, any diabetes or any
Like
disease called leprosy?
my father the same.
Okay. Have you ever had any contact with a patient who has a disease called leprosy or similar numbness or similar facial features?
No, I don't know what this diagnosis. What's this?
Okay, no problem. I will explain it to you later. So, I will ask you a few social questions. Do you smoke or drink alcohol?
No,
Okay. What's your job exactly?
I'm a mechanic.
Okay, how is this affecting your job? It must be really difficult.
Yeah. Since 3 months, I can't do my job well. Affected me.
I'm really sorry for your suffering. I will try to refer you to the social worker and occupational health therapist. They will help you with this matter. Okay?
Thank you.
Okay, so I will examine you now, Mr. Razak. Okay, so I will start the examination by looking at the face of the patient. And I will check this rash if it's painful or oozing.
No,
Okay, then I will examine the hands of the patient, both of the hands. I will check for this clawing of the hand, and I will palpate for any, if any nerve, if the nerves are palpable or no.
palpable nerve, little palpable, but not too much. يعني. You can feel ulnar nerve, but not too much.
Okay, then I will do the sensation. I will check the sensation of both hands. I will check the light touch and vibration.
Affected on the right hand on the same side.
Okay, then I will check the power.
How can you check?
I will check the power by making first the hand grip. Then I will ask the patient to stretch his hand, and I will check the ulnar part. I will ask him to push me.
It's difficult on the right side, same.
Okay, I will check. Then I will check the ears if it's thick and nodular.
Oh, it is as you see in the the in the picture.
Okay, then I will proceed and check the lower limbs, and I will check the sensation of the lower limbs
How will
by
you check?
light, touch, and vibration.
Yes, tell me how what you will do.
I will check the light, touch, and vibration.
Yes, you will check the sensory level or what? What you will check?
Yes, I will check the sensation in both feet.
Yes, it will reach to the below knee.
Below knee.
Check it
Then
too.
I will check the power as well. I will check tone power reflexes of both lower limbs.
Power is okay. Reflexes is okay. Only
Okay,
the main break affected.
okay. Then I will proceed to check for any lymphadenopathy or any hepatosplenomegaly.
There is anterior cervical lymph node on both sides.
Okay. There is. I want to check if there is. Hmm. Okay, you send this picture. This is the back of the patient. I will check these areas if it's there is hyposensation.
Yes, there is
Okay.
hyposensation.
Okay. So, Mr. Razak, what's your
2 minutes
concern?
left.
Yes, doctor, what's happened for me? It is dangerous. Will my hand come back?
Okay. So, after taking history from you and examining you, I believe that you have a condition called leprosy, which is an infectious disease, and I believe that you might have caught it when you went to Nigeria, for example, and it actually appears after close contact with an affected person. And I'm sorry to tell you that it can be really serious if not treated, especially given your case that the infection is disseminated in different parts of your body. And regarding your hand, whether if it's gonna come back or no, we are not quite sure of that. But unfortunately, there is a chance that it will not come back. But we need to do some testing first. So for now, I need to admit you to the hospital to do some testing for you. and we might even need to isolate you. That will be according to the infection control in our hospital. We will check with them. Then we will take a sample, we'll take a sniff from your skin, and we'll do for you some blood test as well. Is that clear so far?
Yes, doctor. Thank you.
Okay, do you have any more questions?
No, thanks. About
Okay.
my driving, doctor, I can drive?
Regarding driving, if this problem affecting you with driving.
Yes, I feel my hand not good.
Okay, so since your hand is not good, I really advise you to stop driving for a while until we fix this issue.
Okay, doctor. My partner is in risky for her. I should tell her.
Yes, when you have a close contact with any person, there is a high risk that they will caught this disease. So in this meantime, I really advise you not to contact with any person.
Okay, doctor. Thank you.
Okay, time is up. Examine the questions.
Yes, doctor. Give me your positive finding.
Okay, I have seen Mr. Razak, a 34 years old male who presented with the right-sided hand numbness and weakness. He has features suggestive of ulnar nerve palsy for 6 months now, on a background of uncontrolled diabetes and a history of travel to Nigeria 3 months ago. On examination, he has swelling in his face with some nodules in his ears and features suggestive of leprosy with hypopigmented areas in his back. He also has features suggestive of diabetes complication in the form of frothy urine and fullness after meals. So I believe that this patient has features suggestive of leprosy. Most likely he caught them because of his low immunity due to uncontrolled diabetes. So for now, I need to, first of all, to control the diabetes of this patient, and we need to treat his leprosy and involve an infectious disease doctor and a diabetologist as well.
Your differential, doctor?
Okay, my differential diagnosis would be neuropathy related to diabetes, mononeuropathy related to diabetes. It could be ulnar nerve entrapment or vasculitis.
That's how you will manage the patient, your investigation?
Okay, first of all, I will do a baseline investigations, including full blood count, renal function test, and liver function test. And we can do ECG and echo as well to look for complications of diabetes. Then I will do specific investigations to look for leprosy. I will do a skin biopsy and send it for microscopy and microbiology and culture. And then leprosy can be diagnosed clinically actually, but we also need the skin biopsy. And then we have to control the blood pressure, control the blood sugar, sorry, and treat the complications of diabetes.
Okay. What's your treatment?
Okay, my treatment would be antibiotics according to the guideline. I believe that this patient might have multibacillary leprosy. So I think the treatment might include rifampicin for 12 months.
Only rifampicin?
To be honest, I'm not sure about the other medications, but it will be according to the guidelines.
Okay, okay, doctor. Thank you.
You're done, Dr. Muhammad, with the question?
Before, during the concern, I help to trace the contact. It's very important. Isolation. It is like mycobacterial TB. It is the same, but it is leprosy. So notification, isolation, contact tracing. We mentioned خلاص التوقفية. Okay. But still there is investigation still something. She covered it superficially يعني, not deep. Will comment Dr. Bassam? Will you have any question for her?
Yeah, she covered all the skills, the differential, clinical judgment.
Regarding the history,
Okay,
is
now you
taken.
can comment based on the skills. I will share the skills.
Yes. Give me the skill, then we
Okay,
can.
the chat box.
Yes. From the physical examination, طبعا there is ulnar nerve palsy. طبعا this case coming for diabetes complication and association, and one nerve pulse examination. So from the examination, طبعا there is very important Froment sign and water print, في Waterberg sign. When you give her the paper in between your ring finger, between your thumb and hand, and to the patient, you will show the adductor pollicis affected. He will flex his thumb and not adduct it. So it will confirm the nerve palsy. طبعا, and sensory, it should be continue to see if there is any sensory level there. During the examination also should ask any scar up to the axilla, any scar there, any scar in the back of the neck, any trauma during the history. She didn't ask about any trauma there. So sensory and motor and functional examination. She should ask him to take any key or anything to check his functional status. And these two signs very important, Froment and Waterberg sign. She will tell him to open his hand. She will found that his little finger away from the other fingers. This is regarding the examination for the ulnar nerve. The main cause, diabetic and leprosy. She didn't ask about any other to discover whole back and front to check any other hyperpigmentation. And even if she didn't discover this, she should examine sensation of the granulomas in the face. She should test it also by cotton or something to ask him if it is sensing this or any sensation there to confirm it is a leprosy. طب she did well about the stroke appearance. Yes, the diabetic complication, diabetic neuropathy. This is regarding the examination. يعني we can say borderline because it's very important sign missed. Okay. The history, I don't know the history, the communication, the history. During the she know that about the diabetes very long and he's not compliant. And asked him any problem you know about the diabetes informed to you. I think it should be directly ask him any heart attack, any stroke, any and then asking about directly the complication, any pain in your limb during walking, any intermittent problem,
The hypoglycemia as well. Yes.
and the hypoglycemia also, right? تمام. So يعني in the history I feel يعني she touched the important point, then go away. I will come back to you. I think she should be directly better, يعني directly finish it early. And the other association as autoimmune, you are not clear to the examiner that you are associating any dizziness, you're standing up, any tanning of your skin, any طبعا you asked about lose motion, right? Any pain, numbness, if anyone tell you you are bone pallor, any yellowish of your eye. To finish in one line about the association of autoimmune. So as a complication of diabetes, uncompliant person, and because he is already coming by diabetic neuropathy as a ulnar nerve palsy from the second differential diabetic neuropathy. And as you mentioned, interrupting the carpal tunnel syndrome, it is also a differential test. I don't know, I can comment more, Dr. Basim, about the history, if it was organized or not. Really, I was concentrating about the signs and the judgment after that. Yeah. But this is the most important as the examiner
Yes.
waiting about
Okay.
Yes, about the history. Once you reach the key of the case, that patient long-term diabetes only on metformin, she was not compliant. How come 8 years and he's told you that he has numbness of his lower limb and frozen urine, so is not controlled and not compliant, should be على طول directly ask about the complication and association of the autoimmune. Second thing, طبعا this is يعني it is a rare case to come at the leprosy in the exam because it is effective, but it is effective by very close contact, long time close contact, not by shaking a hand or something like this. But it is a case for granulomatous micro TB, microbacterial tuberculosis and microbacterial leprosy. It's the same idea. يعني. Yes, about the we finish the examination and find sign. طبعا as usual the examination it will take time as you mentioned Dr. Kutuf before, it will take time, so you will target it but you are not يعني clarifying what you will do for the examination to be clear. يعني give the even you mention in front of the examiner I will do this sign, this sign, this sign. If it is not clear, even he will accept. I think that you know about the sign symptoms of this complication. About about the investigation, yes. About the judgment and investigation, you mentioned skin scraping or smear and doing PCR for it is good for the main cause. But what about nerve conduction velocity for the sensory loss? Also the carpal tunnel entrapment. Okay. Beside the basic lab, as you mentioned, DSR therapy for inflammatory or for infection or anything, يعني is very important also. KFT and urine protein create ratio for proteinuria, hemoglobin A1C. All this is very important to mention for the patient. TSH also should be mentioned, the association for the autoimmune. Okay, about the treatment, as you mentioned, infection disease, multidisciplinary team, infection disease, and neurologist, and sometimes they mention also orthopedic also. Because one of the differential, very important differential, he is telling you I'm a mechanic and maybe by repetitive using his hand, maybe some injury there, might any trauma there. It should be mentioned in industrial injury. It's very important also on the differential, and that's why he sometimes need orthopedic and neurologist to confirm after nerve conduction velocity if he need any intervention urgent to release the nerve. Okay. About the treatment, طبعا it's not common. It is like TB. He has regimen 6 to 12 months, 3 tablet, rifampin, clofazimine, and dapsone. The question here was if you mention dapsone, very important to tell that I will do for him G6PD enzyme level before giving dapsone. And this is judgment for this treatment. He wanted to hear for you dapsone to ask you any specific test you wanted to do before giving him. Okay, and طبعا rehabilitation program for his hand. If the neurologist no intervention surgically for him, rehabilitation, as you mentioned, occupational, social, physiotherapy, very important rehabilitation for the affected limb. In the history, very important question. This you asked about any fits, any why you asked about fits, Dr. Kutuf? Hello? Hello?
Yes, doctor.
Yes.
Why you asked about fits?
Because this is a neurological problem. I thought there may be a problem in the brain. That because before I knew the leprosy.
Yes. As a neuro,
Plus that before
as a
that
stroke,
was in the history presenting illness before I saw any picture of the patient.
أيوة. As a stroke يعني. No other thing in your mind about this? This picture of hand, any other differential?
This is actually mononeuropathy.
Yes,
So
we mentioned leprosy, ulnar nerve palsy, by leprosy, by diabetic nephropathy, by industrial injury. Any other thing you need to exclude by history?
nothing in my mind actually.
Yes, very important in this case, this picture of tetany. So it's very important to ask about any numbness around your mouth. You mentioned any abnormal movement, any fits, but the specific question about this any numbness around your hand, and during examination, offer I need to rule out hypocalcemia. I need to do kivostic sign and torso sign.
Yes, but hypocalcemia usually comes in cramps, not in clear ulnar nerve palsy. In crampy
Yes, but
hands, like
sometime
carbopedia
coming,
spasm, like spasm.
sometime come carbohydrate spasm like this.
Yeah,
يعني
but it is carbopedia spasm. It's not a real ulnar nerve palsy. So this patient is having a real palsy with weakness and numbness for 6 months. It couldn't be hypocalcemia.
Okay, doctor, I am telling you what is the calibration for the case as you want, but
Yeah,
I have seen many cases by this carbohydrate spasm coming by this hand. Okay, so
yeah,
it's
it's
very
like this
important.
hand. That's why I asked first if you have cramps, if it's cramping and going back. That was my first question.
Okay, طب why didn't you
Because
put it
it's
in the differential?
because the patient has real weakness and numbness. Hypocalcemia doesn't cause mononeuropathy. He had ulnar nerve palsy. It is the same shape, but it's not the same problem.
We will remove it from the differential. Okay,
Yeah, I don't think I can say hypocalcemia for ulnar nerve palsy.
that's okay, doctor. I finish my comment. Okay,
Okay. And other thing, doctor, this is not an autoimmune disease. This diabetes is not autoimmune. I don't think that this is type 1 diabetes being diagnosed as 26 years old and treated with metformin only. So I don't think that the autoimmune screening will give me any benefit here. It will be unnecessary given the time is already short by discussing the leprosy and the whole thing about diabetes and different complications of diabetes he already have.
yes, you may be right about this. The insulin dependent is not
Yes.
insulin.
Okay,
Thank
thank
you.
you, Dr. Mohammed. Thank you, Dr. Gutov. I don't know what to say. It's first time to hear about leprosy in PACES. I don't know which center it's appeared.
It's me as well. I'm shocked. I don't think they will bring
It's
such
okay,
patient in exam.
but you caught it, Doctor. You caught it. I didn't know really about the from the figures and or the pictures. I didn't know. I thought it's something like mononeuritis multiplex, ulnar nerve injury. But please, never ever miss the trauma.
Okay.
At any case with trauma with nerve injury, always ask about the trauma. It's not the case, but at least know it and ask about it. Okay. By the way, it can come as a short. In the past test videos, there is the same case. It was a trauma patient. So please don't miss the trauma. It can even be a fitting for the differential, and it will be good differential as a claw hand or ulnar nerve palsy. Otherwise, as a leprosy, I cannot comment on this topic because I didn't read about it before. It's not common one. Dr. Muhammad already covered the question, how to answer the investigation. But as any nerve injury, you have to mention the nerve conduction study.
Okay, doctor.
Okay. Regarding the systemic review, yes, you went systematic, organized way. Even the question for the complaint, which is the weakness, you ask it well. What do you mean? How it was affected, and so on. So it was good to approach the case from the start. Otherwise, the concern also was answered well. The examination was for me. All the skills were okay, apart from the differential because you didn't mention the trauma or nerve injury because of trauma. Otherwise, Yes, I think you covered all differential.
Okay, doctor. Thank you.
Okay. We will open the discussion because again it's a rare case. So anyone want to add something? I didn't read about it, so I cannot comment on this.
Okay, honestly, I would never know it if I didn't remember the lion face. This is the only thing I can. I don't even know what is the treatment of leprosy, to be honest.
But the most important to mention the multidisciplinary team. They
Yeah.
will be there. They can put the management plan according to the policy of the hospital. That's enough. Fair enough to mention that whenever you have unknown management plan or unknown pharmacological particularly, but you can mention the all non-pharmacological in any case.
Okay.
Rehabilitation, specialized nurse, uh, like modification, lifestyle modification. Okay, all these you can talk about, but if you come to the pharmacological part, don't say something you don't know. You can refer and wait for the reply.
Okay.
Okay.
Noted, doctor.
Yes.
Thank you very much.
Yeah. Thank you to Dr. Kutov. Well done. Anyone want to add any comment before moving to the chat box? Okay. And let's go back to the first comment was before I move to this scenario, or let me mention it at the end regarding the rash or sorry ARR aldosterone renal ratio. I will summarize them at the end because it was confusing a little bit earlier, but we will correct it to be more clear for all. The first, Dr. Tahani, micro and macrovascular communication of diabetes. I agree to mention and to ask about all the things, particularly the hypoglycemia. If you have one or two hypoglycemia, you might stop driving, not only for the hand issue. As you are asking about the hyperglycemia, you have to ask about the hypoglycemia and try to do them while taking the systemic review question. So when you are in the CNS, you can ask about mini stroke or mini stroke. When you are in the cardiovascular, you can ask about chest pain, aortic heartbeat, heart attack. When you are in the tummy, for example, any change of your bowel, any feeling fullness from small meals, this is for gastropathy. Okay. For the water work, any frothiness in the urine, and any claudication, you can ask any pain while walking. Whenever you are in the musculoskeletal, you finish the hyperglycemia complication, then you can ask about the hypoglycemia. Any attack of hypoglycemia, if you have any of them, you have to stop driving immediately. The other part I want to stress on here, the hemoglobin A1C, which you already mentioned by Dr. Gotov. At least you ask about it, but don't forget the others, okay? Dr. Khalid, very difficult to cover all diabetes with leprosy scenario. Try to summarize and to be more concise the question regarding diabetes. Cubital tunnels fossa, yes, it's one of the area of the compression you mean. EMG, I don't think EMG will be conclusive here. It's nerve conduction, not something related to the muscle. Dr. Hisham has any center gave a leprosy. I'm not sure. I didn't hear about it before. Even I didn't practice in YouTube channel videos. All the session never ever we discuss the leprosy. So it's good from Dr. Muhammad to bring such topic. It will be unique topic and unique session to talk about leprosy. Even in one time, maybe it will come to any one of you. So be ready to answer the question related to the leprosy. Vasculitis, of course, you can say it's vasculitis related. So when you write multiplex, as doctor, someone asked about the systemic review. I post the video of how to ask systemic review. You can open the video. It's only maybe seconds or 2 minutes. So you will not take long while taking the questions of systemic review. Just listen or watch this video, doctor. It's very important to know how to ask systemic review in organized way and quickly, not only organized way. Okay, so you have to start from up, downward. Whenever you do so, you will impress the examiner. Dr. Hisham, again, this seems more like a short case. Yes, it could be. Nice history for the symptoms. Ask one by one. This was a weakness, not just numbness. We do EMG. Yeah, if you suspect myopathy, you can do EMG. But if you have suspect neuropathy, so it's nerve conduction study. However, if you have any weakness, yes, you can offer it. Okay, but I mean, to be more conclusive, the nerve conduction study will be the diagnostic. I hope no one get this case in exam. Actually, by the way, it can be differential of vitiligo. I remember vitiligo as hypopigmentation. Leprosy you can put as a differential, but don't. I didn't hear. I mean about leprosy as a long per se, but it can be a differential of hypo or hypopigmentation. In brackets, the vitiligo. So you can mention it. Leprosy also comes as dorsalis pedis, as I remember. Sorry, it's not dorsalis pedis. It was like syringomyelia. Okay, differential. So the weakness, the hypopigmentation, the neurological manifestation, all can be as a differential, but it's not very common differential. So don't put it unless you are sure this is hypopigmentation. You have to say this is a hypopigmentation, so I can think about leprosy if there is numbness over it or decreased sensation over it. Okay. Also, tinea. Okay, you can say in dermatological differential. Tinea, yes, you can put, but tinea will not cause any nerve conduction problem or any nerve or neuropathy. How to explain claw hand with hypocalcemia? So you can, to the patient, you mean, right? Or to the examiner?
No. I think Dr. Muhammad was asking about the question, and he was saying that hypocalcemia, and that's why he's saying something like a perioral numbness and tingling. So I couldn't understand that how hypocalcemia. How will you explain this kind of clawing of the hand with hypocalcemia only?
Yeah, suppose you mean the other manifestation will be there, right? Not only claw hand.
I mean, I'm talking specifically about this case, that how you can fit in hypocalcemia into your differential diagnosis.
No,
I
no,
couldn't
it's
understand
it,
that.
it would be bilateral, not unilateral. I cannot put it as a differential because it's bilateral in the tetany, but here it's unilateral. So it's something localized or something unilateral. I cannot say this is hypocalcemia.
And Dr. Basim, hypocalcemia will not be causing claw hand as well, isn't it?
It will cause all the hands spasm. So
Yeah,
the
but
whole hand,
this
not claw.
patient, I
No, no,
mean,
no,
the
not claw.
picture, yeah, in the picture which have been shared, it's a claw hand. It's a
Yeah,
clear-cut
yeah,
claw hand,
claw.
isn't it?
Yeah, yeah, it's claw hand. But in the or the hypocalcemia tetany, there is
It
flexion
will
in
just
all
be spasm.
fingers.
Yeah, it will
Spasm,
be,
yeah,
yeah,
flexion, exactly, yes. So it will be all hands, not all fingers, not only the
yeah,
lateral, yeah,
yeah.
individual fingers. Okay, doctor, could you repeat again the difference between EMG and nerve conduction study in neuropathy and myopathy? It's yes, nerve conduction study to diagnose any neuropathy, and electromyogram to diagnose any myopathy. This is the only difference. So they are both of them as neurophysiological study, but one for the neuropathy and the other for myopathy. That's it. This is the only difference. No need to know more about or detailed information about. But you have to know there is axonal and there is also demyelinating, and the velocity and the other the velocity, and the other thing is the what you call it, the nerve conduction diagnosis, the velocity and what
Yeah,
amplitude,
latency,
no, no, the amplitude, yes.
latency basically. So you know,
The amplitude. So the amplitude and the
yeah,
velocity. Yes.
yeah.
In the demyelination, the velocity will be affected. For the axonal, the amplitude will be affected. Okay. Axonal, of course, you have to know the cause of axonal, diabetes and other disease. And for demyelinating, you have to know the most common cause of demyelinating. On the top of them is multiple sclerosis. GBS also demyelinating disease. Okay. Any question? Any added point before ending the session? Satisfied all? So thank you, Dr. Muhammad, Dr. Gutov. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa
Thank you,
rahmatullahi wa
doctor.
barakatuh. Okay, thank you, Dr. Gutov. Well done.